Hello everyone. Hi,
Hello.
I'm Dr. Kumar Utsav and I'm beginning today's presentation on difficult asthma, a phenotypic approach. It gives me immense pleasure to have such young talents with me who are both experienced and have the firepower to make sure that you have a fantastic evening with us. To begin with, I have to inaugurate with the most senior member of my team, the most experienced player, Professor Anand Agarwal sir from Sonepat, from BPS Government Medical College, who is professor and head of the Department of Respiratory Medicine. Welcome sir to the
Good
presentation.
evening. Welcome. Thank you.
और क्योंकि माहौल बहुत राममय हो गया है, तो हम श्रीराम शेनॉय को जो है इनवाइट करना चाहते हैं, who is consultant pulmonologist from Venkateshwar Hospital in Dwarka, New Delhi. Welcome, Shriram.
Thank you, sir. Thank you for the invite.
Next, my dear friend, Dr. Aditya Chawla, who's a consultant pulmonologist at Jaipur Golden Hospital and Saroj Hospital, kick-ass guy, and did a successful NAPCon recently in Delhi.
Thank you, boss.
Next, again, a very dear friend, Dr. Deepak Muthreja, head of the Department of Respiratory Medicine at American Oncology Institute and Nangya Specialty Hospital from Nagpur. Looking forward to have a very interesting conversation with you, Deepak. और फिर विभू बॉस के क्या कम कहने. Welcome Vibhu sir. Vibhu sir has a speciality in, he's a defined guy by degree who's a respiratory pediatric specialist who's going to answer the pediatric questions we have for today in severe asthma. Vibhu sir is leading leading a hospital in himself with the name of Vibhu Specialty Nursing Hospital in Malvi Nagar in New Delhi. Welcome Vibhu sir.
Thank you.
So स्टेप्स ऑफ एस्थमा के बारे में सबको पता है. एस्थमा की चक्की के बारे में, जिसमें रिव्यू, रिस्पॉन्स, असेस, एडजस्ट, वो चक्की के बारे में सबको पता है. वो सारी चीजें आप करते आ रहे हैं. तो आज की प्रेजेंटेशन हमारी ऐसी रहनी चाहिए, या आज का हमारा थॉट डिस्कशन ऐसा होना चाहिए कि कुछ ऐसा आप लेके जाएं जो आप डे टू डे प्रैक्टिस में आगे जाके अप्लाई करें और अपनी प्रैक्टिस को बेनिफिट करें. मैं कोई भी प्रेजेंटेशन देता हूं, सुनता हूं, तो मैं एंड में यही असेस करना चाहता हूं खुद से भी, और मैं ये चाहता हूं कि लोग भी ये असेस करें कि इस प्रेजेंटेशन से हमारा क्या बेनिफिट हुआ. Taking that forward, I am going to bring forward a short discussion of 10 to 15 minutes with you. Please go ahead with the presentation. Hello everyone, I am Dr. Kumar Utsav from Varanasi. Today, we are going to talk about an interesting topic about difficult asthma, a phenotype-based approach. Before we begin, I want to take this opportunity to thank CCI and Dr. N.H. Krishna, Dr. Narayan Pradeep, and my dear friend Dr. Atri for giving this interesting opportunity to talk about a topic which people don't often approach. Asthma, then and now. Treatment of asthma is both simple and difficult. Majority of our patients fall in the purview of one shoe fits all. It's those small minority of 5% patients who frequent your OPD, those that require your special care, those who constantly nag for your attention because their symptoms are not resolved, those who bother you over and over. Those are the ones you remember. Our today's presentation is dedicated to that subset of patients, the ones you remember because you are unable to treat them. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, cough that vary over time and intensity together with variable expiratory airflow limitation. Airflow limitation may late become persistent. Emphasis on the word of heterogeneous disease. Gina had come up with its pocketbook on difficult to treat asthma and severe asthma back in 2018. The words uncontrolled asthma, difficult asthma, and severe asthma are used interchangeably. What are the common causes of uncontrolled asthma, which is not severe? There is non-adherence to therapy, incorrect inhaler technique, comorbidities, and psychosocial factors, ongoing exposures to asthma triggers. The words which are used interchangeably, but is it right to have 3 words for the same thing. In our presentation today, after this presentation, we'll be detailing and what is difference between these 3 definitions. So, understanding a patient's adherence to therapy is always a prerequisite when assessing severe asthma. The term uncontrolled asthma are those patients who have poor symptom control, frequent symptoms or reliever use, activity limited by asthma, nighttime awakenings due to asthma, frequent exacerbations, that is more than 2 exacerbations per year requiring oral corticosteroids, or serious exacerbations requiring more than one serious exacerbations requiring hospitalizations. Difficult to treat asthma is that asthma which is uncontrolled despite step 4 or 5 or which requires such treatment to maintain good symptom control and reduce risk of exacerbation. Severe asthma is one which is uncontrolled despite making sure of good adherence, right technique, controlling the comorbidities, managing the psychosocial factors, taking care of asthma triggers, and even after doing all this, even after a good optimized therapy, the asthma is still uncontrolled, or that asthma which worsens when we decrease the high dose treatment we have been giving falls under the purview of severe asthma. We all have seen this presentation or this graph over and over. Out of 100 patients of asthma, 24 patients may require step 4 and 5 treatment. 24 out of these 24 patients, 17 patients may require, even after giving 4 or 5 GINA step 4 or 5 treatment, have poor symptom control. Out of these 17 patients, good subset of 4 patients, even after giving step 4 or 5 treatment, have poor symptom control, even after correcting the inhaler technique, having good adherence, managing comorbidities. After doing everything, even then this patient are not improved. This subset requires our ultimate or most attention. हम सब ने ये चक्का देखा है रिव्यू रिस्पॉन्स असेस एडजस्ट का, हम सब ने ये स्टेप्स ऑफ जीना के सीढ़ियां को चढ़ा है, हम सब ने इस चीज को बहुत अच्छे से समझा है और हर साल हम इसी पे काम करते हैं, इसी पे पढ़ते हैं। आज की प्रेजेंटेशन डेडिकेटेड है इसके बियॉन्ड पे कि ये जब फेल हो जाएगा तब आपको क्या करना है। Key 7 steps for investigating and managing patients with difficult to treat asthma. First, confirm your diagnosis. Is it asthma or anything else? Look for factors contributing to the symptom development, exacerbation, and poor quality of life. Optimize the treatment to manage these symptoms, exacerbation, and quality of life. Review after 3 to 6 months after you have optimized treatment. अगर asthma अभी भी uncontrolled है, then a diagnosis of severe asthma should be made. Assess the phenotype of severe asthma. Assess type of inflammation of this severe asthma. Is it type 2 or is it non-type 2? Does it require a biological therapy or it can be managed by non-biological therapy? Review the response you have given in 4 to 6 months. Continue to optimize management and then move ahead. Coming to the concept of asthma syndrome. Asthma, a disease characterized by chronic airway inflammation and airway remodeling, was formerly considered as a single disease. With the introduction of concept of asthma syndrome, the various key clinical characteristics of it were confined under the umbrella term of asthma. This includes features of both asthma severity, lung function, symptoms, exacerbations, and patients with both allergic and non-allergic inflammation. So there is a paradigm shift in defining the asthma from a single disease to a complex chronic disease with marked clinical heterogeneity. Remember, asthma की definition में भी मैंने एक word underline किया था, heterogeneous in nature. यहाँ पे भी हमने एक word को highlight किया, heterogeneity. This heterogeneity is asthma phenotypes. Asthma is heterogeneous, meaning there are many different types of asthma across the whole range from mild to severe. Recognizable clusters of demographic features, clinical characteristics, lung function, and inflammation are called asthma phenotypes. Remember the word recognizable clusters. The term phenotype literally means clinically observed characteristics of a disease. So clinically observed characteristics used to describe asthma phenotypes are clinically maybe age, gender, race, early or late onset asthma in smokers, perimenstrual asthma, exercise-induced asthma, aspirin sensitivity, atopy, GERD, rhinitis, rhinosinusitis, associated comorbidities complicating your asthma, physiological like low FEV1, fixed airway obstruction, highly collapsible airways, fast declining in lung function. Response to treatment such as inhaled steroid sensitivity, oral steroid sensitivity, LTRA, like is Montelukast, Sabasama toxicity, prone or anti-IgE responsive prognostic factors like brittle asthma, near fatal asthma, benign asthma, frequent exacerbators, COPD prone, and remitting or relapsing asthma. Like pathological base like eosinophilic, neutrophilic, mixed polygranulocytic, or goblet cell hyperplasia, mucus production, smooth muscle cell hyperplasia, thick small airways, decreased alveolar attachments, and elastic. There are simply too many definitions for asthma phenotype. इतना कोई भी नहीं समझ सकता. Many of which are related to difference in symptoms and severity rather than difference in underlying mechanism. This kind of subtyping does not take you anywhere. It does little to help understand the prognosis and targeted therapy. When a link can be made between clinical characteristics and molecular pathways, the term endotype is introduced for the same to describe these distinct subtypes with a defining etiology and consistent pathobiological mechanisms. मतलब जो clinical characteristics को molecular pathway के साथ link करके जो phenotype निकलता है, जो that is called true phenotype or endotype. So this definition of true phenotype requires underlying pathobiology with identified biomarkers and genetics. This characterizes patient into subgroups to predict response to the treatment and offer novel therapies to ultimately benefit these otherwise helpless subsegment of severe asthma. Coming to type 2 inflammation or Th2 associated asthma. This is the most prevalent group, consequently well-explored prototype in asthma linked to allergic sensitization in mediated by type 2 helper cells, now termed as type 2 asthma. Progress in managing type 2 asthma has pinpointed a subgroup labeled difficult to control or severe asthma, which exhibits poor responsiveness to current therapies primarily designed for type 2 inflammation. Type 2 asthma forms at least 50% patients of severe asthma. It is characterized by atopy, eosinophilic inflammation, favorable response to corticosteroids. It is characterized by cytokines such as IgE, IL-4, IL-5, IL-13, which are produced by adaptive immune system on recognition of allergens. They may also be activated by viruses, bacteria, irritants that stimulate the innate immunity system. Type 2, the phenotypes of type 2 associated asthma are allergic asthma, eosinophilic asthma, exercise-induced asthma, or aspirin exacerbated airway disease. Coming to the non-type 2 asthma, is there a lack, sometimes in some cases there is lack of efficacy of the type 2 targeted therapy, suggests that there is a subgroup of asthma which develops in the absence of type 2 immunity. Little is understood about non-type 2 asthma and its related molecular elements, that is neutrophilic asthma, obesity-related asthma, or smoker's asthma. So in the early age, we see allergic asthma, then in the mid-age, we see eosinophilic asthma, aspirin exacerbated respiratory disease, or exercise-induced asthma. Later on, the non-type 2, we see neutrophilic associated, smoker's asthma, obesity associated, or polygranulocytic asthma. Our detailing of these phenotypes will continue with our August panel. I thank you for your patient listening, and then we begin our discussion. Thank you so much. I welcome you all.
Thank you, sir. Thank you.
So I hope the presentation is enough to ignite the discussion between all of us. So I'll start with my dear friend Aditya. So Aditya, what is the difference between difficult to treat asthma and severe asthma?
Thank you, Sabas. So, actually, you have already elaborated in your slides. Difficult to treat asthma is the asthma which is not getting corrected with the standard treatment. We need to amp up the treatment. We need to escalate the steroids. We need to escalate the inhaled corticosteroids. We may have to add oral corticosteroids to control the asthma symptoms to a manageable range in a good control. So that is a difficult to treat asthma. Whereas the severe asthma is even after good therapy, even after the optimal therapy or an increased therapy, the symptoms are not coming under control, and the patient is going to require extra care of ICUs and injectable steroids and injectable derifylin and everything. So that is a severe asthma.
Great, Aditya. So, Aditya, what would be the triggers of this severe asthma?
So triggers can be anything in your environment, from pollution to temperature to house dust, from dust mites, then pollutants, and anything in your environment can irritate you. Green vegetables can also irritate you. I was surprised to see one allergy test I did today in the morning. So the person came out to be allergic to peanuts. It came out to be allergic to coriander. He came out to be allergic to cockroaches. Then so many things are in the environment which can be allergic to any person, and it is very specific to the same person. So everybody has their own triggers. Can be temperature, can be weather, can be pollutants, can be anything, can be smoke. Even the tadka you use in the houses when you are making the dals and the sabzis, they can also precipitate your asthma.
I think that is very elaborative, especially the tadka part. So, Shriram, what are the comorbidities in severe asthma?
So, sir, as we all know that severe asthma as it is a big deal to treat. The comorbidities that we see add fuel to the fire and make it even more difficult for us to treat it. Most common associations, such as which we routinely see, is with allergic rhinitis. Then we may also have the often overlooked gastroesophageal reflux disease, obesity not only via the leptin adiponectin network makes it difficult for us to treat the asthma. The responsiveness is reduced. Plus, it also has mechanical effects on the disease response. Also, obesity, hypoventilation syndrome, and obstructive sleep apnea are most overlooked comorbidities in severe asthma. And as we may see ahead, allergic bronchopulmonary aspergillosis is also one of the important comorbidities.
Wow. So, what steps are to be taken to come to and confirm the diagnosis of severe asthma, Deepak?
A very practical question. So, severe asthma is actually a subset of difficult to treat asthma. Once you have found out that the why patient coming down to you has a difficult to treat asthma, first you need to confirm the diagnosis. You have to see for the differentials of asthma, like whether there is vocal cord dysfunction. Then you have to see for different contributing symptoms and comorbidities which were mentioned earlier. Once you have seen these things, and then you have to optimize the management. If the patient is already on high dose inhaled corticosteroids along with long-acting beta-2 agonist, you have to add a LAMA to it. You can use LTRAs. You can use all non-biological therapies. Even after that, after this, you have to review the response within 3 to 6 months. If the patient's asthma is uncontrolled, the patient is having night symptoms, daytime symptoms, daily loss, then you label these patients as severe asthma, which is actually 3 to 5% of our regular practice.
I think that is great. But यार एक बात बताओ आदित्य, यार पेशेंट जैसे आता है, we have got the steps from Deepak, but पेशेंट हमारे पास आता है, पेशेंट वीज कर रहा है, हमने एक अच्छा अस्थमा का ट्रीटमेंट दिया हुआ है, and patient is not improving. So मतलब how do you go about it? What can be the alternative diagnosis? What should we investigate? How do we investigate this patient?
So first of all, we need to confirm that the therapy that is going on is correct. Therapy हमारे को पूरी करनी है patient की. We need to give them inhaled corticosteroids. We need to give LABA, LAMA. Then we need to give him the derifylin. We need to give him everything which is required to treat asthma. Then after that, if it's still not getting corrected, we need to look elsewhere. Now elsewhere कैसे देखेंगे? We need to get a CT done for the patient to diagnose that the patient is not having any underlying lung disease. Patient does not have any history of foreign body inhalation. And if everything comes out to be normal, we can do a check bronchoscopy. There are some cases which we have seen that the patient was having endobronchial carcinoid and endobronchial foreign bodies, which led to the wheezing, and the patient's asthma got exacerbated because of that also. So we need to look everywhere like GERD, obesity, OSA. So we need to investigate everything that this is not exacerbating our asthma symptoms, and we need to correct that part also.
So, have you seen any foreign body inhalation which is leading to wheezing? Because I have seen a case. एक बच्चे ने एक सीटी इनहेल कर ली थी,
Correct.
मतलब
The same thing, boss. The same
या
thing.
सीटी पूरा उसने इनहेल कर ली थी, एंड वी सॉ दैट वो सीटी इनहेल कर ली, वो सीटी स्कैन पे दिख रहा है कि उसके अंदर पड़ी हुई है. देन आई पेशेंट इज व्हीजिंग लाइक एनीथिंग, we had to sedate him, we took out the वो patient एकदम normal हो गया. So this is very practical. Foreign
Correct.
body inhalation, foreign body aspirations into lung have been a real problem, and those
I
patients
think
can
it's
present
more
as
common
asthma.
with the. I think it's
Yeah.
more common with the pediatric
Yeah,
population.
of course.
This kind of
मैंने
thing.
भी
I
जो
see.
patient की
Mostly common with
bronchoscopy
the
करके दिखा,
pediatric
that
only,
was a
boss.
pediatric patient.
Yeah. I had a case recently where वो जो ढोलक के ऊपर एक छल्ला होता है,
हाँ
वो
हाँ
बच्चे ने गले पे अटका रखा था, and he was wheezing for nearly about 1.5 years or so. उसका चल रहा था, मतलब जगह जगह ट्रीटमेंट लिया, ये वो, किसी ने उसका एक्सरे नहीं कराया था. मैंने एक चेस्ट एक्सरे कराया, वो छल्ला पड़ा हुआ था, मतलब there was nothing, there was no issue because it's a inert body, पर वो सिर्फ गले के पास वहां पर वो अटका पड़ा था, वो ओपनिंग के साइड पे. मैंने कहा यार, मतलब वो लेकर 1.5 साल से बच्चा घूम रहा है आराम से, पर किसी ने एक्सरे नहीं करवाया, उसका पीएफटी भी हो रखा था. एंड द ब्यूटी वाज द पीएफटी वाज नॉर्मल, उसका सब कुछ ठीक था, बट वो बच्चा बच रहा था.
नहीं, that is the most important point we take. Your basics are the most important thing. If you get the basics right, many things will fall into order. So Anand sir, आप एक मेरे को बताओ सर, do you use FeNO in your OPD?
Currently not, but I am very much fascinated. So it has been procured earlier because we are working in a government setup. So it is not easy to procure everything.
But what should be the role of FeNO in a routine chest OPD?
Yeah, it is very interesting device to diagnose the cases of especially the eosinophilic lung diseases. And if we talk about in terms of bronchial asthma, especially the bronchial asthma is attributed with the eosinophilic lung disease, and FeNO, or we can say the fractional nitric oxide detectors is very useful to make the diagnosis of such ailments. Not only the bronchial asthma, but also the other ailments which are nearly related to it can also make hindrance in the diagnosis. But few guidelines which has been circulated by the ATS and ERS as well as GINA, which gives the cutoff value of the FeNO. So we can give a point to the patient care when we measure the nitric oxide level in the breath. So if it is more than 20 or more than 25, if we talk about the adults and the pediatric age group, so there are some difference of opinion in the ATS and ERS guideline as well as in GINA guidelines. So if we talk about in adults, if it is more than 25 part per billion, then it will be considered as the patient may be eosinophilic lung disease. But we can make the diagnosis of bronchial asthma when it is more than 50 or higher. And similarly, we talk about the pediatric age group, it is around 20 part per billion to 35 part per billion in practice that can be diagnosed. So there is a range of this FeNO that is for the adult around 25 to 50 and for the pediatric 20 to 35. So we can make the diagnosis. So it is very useful in making the diagnosis. Not
It is
only
very useful because it is not very costly test, easy to do, very handy, can be done, not a lot of expertise
generally,
required.
we can say if the patient, if we go for the diagnosis, then sputum eosinophil count, if we detect, then it is very cumbersome. And if we talk about the FeNO, it is just a replacement of this sputum eosinophil count. So we can detect the nitric oxide, which is actually this signify the eosinophilic lung disease, and we can check the condition of the patients in the OPD even. So we can make a quick diagnosis.
Yeah, wonderful, sir. मैं एक just thought provoking question पूछ रहा हूँ. Anybody of us is using bronchial provocation test in their center?
No, sir, not routinely.
Anybody has an experience of using bronchial provocation test? Because I have never used.
No.
It is quite risky actually.
It is quite risky, but
yeah.
it is yes, again, जिसमें आप PFT से diagnosis नहीं बना पाते हो and FEV1 is more than 70%, you can मतलब give it a try, but of course you should have the learnings to do it. Never do it without an expert. विभू सर, आप बहुत देर से शांत बैठे हो and you are the specialist pediatric respiratory specialist amongst us all, and every single one of us sees at least 10 to 15 to 20% of our OPD practice is less than 20 years of age, less than 18 years of age, right? So is it always asthma in children, or how do you come to the diagnosis of asthma in pediatric population, especially those who are unable to do PFT?
So first thing is, Dr. Utsav, I would like to correct you where you said कि जहां हम PFT से diagnosis नहीं बना पाते. Let me be very clear, यहाँ पर हम PFT से diagnosis बनाते ही नहीं है. ठीक है, that is how we work, because see, with most of the children who are really young, it's very difficult to label somebody as an asthmatic based on the PFT, because you won't be able to do PFT in such a young age group. So now coming to the point, is it always asthma? Most of the times, no, it is not asthma. They may be just a transient wheezers. There may be children who are early onset wheezers, transient wheezers, or persistent wheezers, which may be there, and they'll get all right by the age of about 5 years of age. Another issue is, if you would have seen in last about 2 months or so, I think everybody amongst us must have experienced a lot of children coming with the wheezing, and most of them had a viral issue. So, when there is a viral issue, there is a lot of wheezing which is there in these children. Apart, if you see, I've seen even children with the mild chest infection also coming to us, and they have some amount of wheezing, and you give a course of antibiotic and they get all right. So it's not that it's always asthma. So with children, it is slightly difficult to diagnose asthma per se when it comes down to saying that okay, it's very easy कि आप एक PFT कर लो. So it doesn't work that way. Now coming to the point that if you have a child whom you're following it up, and they have a typical history of a seasonal variation which is there, so history again becomes important. The family history is very important. So and the child is wheezing constantly during particular seasons, then obviously clinically you do label it as asthma. Then if you are able to do PFT, good enough. And what I've seen recently is, because I'm a part of a project by WHO on pollution too, that these children don't tend to have a very good reversibility even with the bronchodilators. I mean, I'm talking of the children between the age group of 8 to 12 years. So I'm a part of that project. So it becomes, again, now you don't label them as COPD, and you don't label them as asthmatic. So that overlap kind of a thing may be there, so that becomes a bit confusing at times. So what I would say is that mostly go for the clinical part. Now if you want to go for the evidences, like we can have a total IgE in the blood test, we get the CBC with a total eosinophil count, we get the IgE levels done. Then there are certain cytokines like the Th2 cytokines, like the IL4, IL5, IL9, IL13. So that you can go for those. But I think most of the cases it's diagnosed on the basis of clinical, with PFT as a support to a large extent, and these eosinophil count and probably the IgE. That is what we normally do in our OPD practice. FeNO definitely is good, and I think one of my friend is doing oscillometry. He's a known personality in our CCI too. So I think oscillometry is something which is being done, and I think it is quite acceptable in the pediatric age group.
So Deepak, you are working in a surgical setup, I guess. It's a predominantly surgical setup.
No, it's like a multi-speciality unit.
Multi-speciality. Okay. So you are using iOS, right?
Yeah, I'm using.
So interesting question has come from Bangalore, Karnataka, about the use of iOS in pre-operative evaluation and fitness for surgery. Are you using iOS in pre-operative? Because you're just going for...
I am going mainly for FEV1. See, firstly is your clinical examination. You see whether the patient is really having breathlessness or not. If patient is having COPD, then you do your FEV1. In bronchial asthma patient, FEV1 plus maximum voluntary ventilation. We do MVV of these patients, and if it is more than 50% of predictive, we give the fitness. We also do EBG. So preoperative fitness is mostly relied on your FEV1 per se, and that
FEV1 more than 1.5 liters, that is the criteria that is being used, I guess. जो किताब है उसमें तो यही दिया हुआ जो last I remember.
right. But if the patients, mostly I'm relying on the MVV criteria. That is, if it is more than 50%, then the patient can be taken for general anesthesia surgery. Basically diagnosed asthmatic patient, and asthma, we all know it's mostly a reversible kind of disease. So in that, you optimize the patient with proper bronchodilator, and then you subject them for the surgery.
Okay. So anyone using FeNO here? FeNO in their setups? Yeah. Deepak, so tell me, you have experience of FeNO in your setup. In asthma, of course, you're doing it in every patient. What about asthma mimics, Deepak?
So asthma mimics, as you are telling. So in those, most of them, the FeNO is normal. Nasal FeNO is also being used for doing primary ciliary dyskinesias. Also, we are using FeNO. In those patients also, FeNO has a very important role. But per se, if we see for eosinophilic inflammation, we are using this FeNO. Other asthma mimics, if we talk about, like I talked about the vocal cord dysfunction. Many times these patients do have wheezing. So what happens whenever these patients get anxiety or panic attacks, these patients try to eject their vocal cords. And due to this, there is persistent wheezing, and they are very oftenly mislabeled as asthma. These are young females who come with little bit of emotional disturbance, some or other kind of.
That is extremely common. That is extremely common.
We do
We
see
also have impulse.
Yeah.
Yeah.
So I guess Dr. Prasanna Kumar from Bangalore, this answers both your questions. So Shriram sir, आप बहुत देर से शांत बैठे हो. मेरे बताओ specific biomarkers you use for to identify patients of severe asthma.
So many of them have already been elaborated by our esteemed panelists, but trying not to repeat, blood eosinophils are, I think, one of the most highly researched biomarker for asthma. There is an arbitrary cutoff, few say 200, few say 300 eosinophils per microliter, and they are used to predict the exacerbations in various studies, the response to corticosteroids also. Then sputum eosinophils is again used in the, quite researched to predict again the response to corticosteroid therapy. IgE, as we all so very frequently use, not only in asthma but also it is we don't have the apparatus to measure the free IgE levels, but IgE is most often used, even to see the biologics, the response to biologics also. Also, there is most of the biomarkers are mostly lab-based and, not frequently used by, I don't think, any one of us, such as periostin, lipoxins. Then we have certain urokinases, then HSCRP. All these are mainly research-based biomarkers for asthma.
But for day-to-day, Shriram sir, sorry to interrupt you. मैं एक पूछ रहा मतलब for people sitting in somewhere in a type 2 town, type 3 town, like Lucknow, like in Varanasi, in Kanpur.
Lucknow तो type 1 है.
हाँ नहीं मैं तो मतलब ऐसी मतलब we have to have a very मतलब like for things they can do at their center and get through the diagnosis. Please go ahead.
So I think blood eosinophil levels are routinely done by most laboratories.
Absolute eosinophil count.
AC, and then you also have IgE.
Yeah, easily available.
And now I think FeNO has become kind of more common than what it was.
Sputum eosinophil percentage, I guess.
Sputum eosinophils also, yes.
Yes.
2% का cutoff है in most of the studies, the large multicentric studies that have been done.
So, मैं simultaneously questions I'll be taking from the chat box, and Dr. Dinesh from Rajasthan, Bhilwara is asking a question to all of you: is how much fraction of your OPD patients are clinically suspected of bronchial asthma are found to have an obstructive pattern on spirometry? This is a very practical question, Dr. Dinesh, and I can tell you, starting from my side, obstruction and the bronchodilator reversibility probably in 20%, I guess 15 to 20%. That is my answer. Anand sir, आपको कैसा PFT में मिलता है sir? पता है?
Yeah, bronchial asthma is near about 12 to 15% cases we observe in our
जैसे जो
OPD.
classical obstructive pattern है,
Yeah, that is 12% reversibility, or we can say absolute change 200 ml, more than 200 ml in FEV1. That will be considered as a criteria. So such patients are generally 12 to 15%. They are classic. But if we talk about in terms of FEV1 only, then we can't say these all are the patients of bronchial asthma, because similar pictures of in the PFT will be seen in different uh, kinds of ailments which mimic bronchial asthma, like eosinophilic lung disease, TPE, tropical pulmonary eosinophilia,
they
Loeffler
have
syndromes, and
included
all.
that in the definition of asthma itself, variable
Yeah.
over time and intensity, and that bronchodilator reversibility may become later on may become persistent. That is the new definition of asthma, I guess, right?
But
Deepak, what's your
chronic
thoughts?
diseases, if we talk about the chronic ailments, then asthma will be considered. But a few acute conditions will also mimic just like a bronchial asthma, like viral diseases and
Yeah,
all.
of course.
So that should also be excluded, because once you will label them as a bronchial asthma, probably they don't need a prolonged treatment, as because once the trigger factor can be alleviated, so the symptoms get subside.
Okay. Shriram, what is your experience of this question? Obstruction findings in a case suspected of asthma, like a classical.
Classical, sir, I think in line with around 20%, in line with the others.
Okay, 20%.
Well,
Vibhu
pediatric
sir?
age group, I would say it's not even 5%. So that's there, because most of them are not even able to do properly the PFT part.
correctly.
And the second thing, it's easier said than done. As sir said, that once you label them as asthmatics, remember one thing: we are the ones who get the maximum bad words for labeling them as asthmatics. You label a child asthmatic, it becomes a big issue for the family. So they are like, they run around
Bronchitis
and
लिख देते हैं सर हम लोग तो, एलर्जिक ब्रोंकाइटिस.
हाँ, वही करना पड़ता है.
Bronchitis.
हाइपर रिएक्टिव एयरवे डिजीज हो जाता है, कुछ भी लिखो, बट एस्थमा मत लिखो.
Asthma
बट
मत लिखो, दमा मत लिखो.
the thing
This
is that you have
is
to,
a
I
real
think,
taboo.
yeah, it's a taboo, but I think we at least at my point, I'm lucky in that sense that I'm amongst the very few pediatric pulmonologists over here. So the patient has been to different pediatricians, and when they come to me, it's easier for me to tell them that, look, this is asthma, whether you accept it or you don't, it's your choice. So it's once you accept, it becomes easier to really go ahead with the treatment part, and with all the precautions and everything. But yes, acceptability is definitely an issue, and we are the ones who face the maximum music. So PFT, and not getting a classical PFT picture, and with the Google event of Googleopathy, I think it becomes really difficult, because आप PFT करके उसके हाथ में आपने PFT तो पकड़ा दिया, वो बैठकर AI से अपना वो पूरा इंटरप्रिटेशन लेकर बैठा है कि डॉक्टर साहब आपका तो ये रिवर्सिबिलिटी नहीं है, ये नहीं है, आपने मेरे बच्चे को अस्थमा कैसे कह दिया. So it becomes a bit of an issue at times.
सर, मतलब आप ही से, विभू सर, आप ही से एक क्वेश्चन है मेरा फॉर द ऑडियंस, लाइक व्हाट आर योर थॉट्स ऑन अर्ली ऑनसेट एलर्जिक एस्थमा सर?
आई थिंक पूत के पैर पालने में नजर आ जाते हैं to a very large extent. Let me be very clear on that. It does start at the pediatric age group. It's rare that we do come across the IC adults also. So when they come to me at the age of 25, 30 and all, and when you go back to their histories, they do have an issue of asthma in the early life. And the best part is that you take the history, because the family history is very important. So it may be there in their parents or grandparents, or maybe in the brothers or cousins and all. So it becomes easy for you to go for the diagnosis. So early onset asthma, as I said, that wheezes वगैरह भी होते हैं, but उनको asthma में label करने के लिए, I think the family history becomes important. And sometimes it's actually retrospectively that you are able to diagnose them as the asthmatic. So the child is coming to you for a decent period of time, and then you go back to the history, and then you convince them, so it becomes easy. So it's only about the early onset asthma. Is those who are wheezers may persist, to be asthmatics later on in life.
So again, what biomarkers do you use for early onset allergic asthma? What is the presentation? What the family history? Let's say early onset allergic asthma is probably the most common phenotype, one of the most common phenotypes, has positive family history. Patient again,
I think the first thing
atopy
is that
association with atopic dermatitis, rhinitis, and
so
all these.
yes, rhinitis, dermatitis is again very quite common because,
Hmm.
and these children, even at the age of about 1 year of age, you start getting some eczema issues and all with these children. So yes, they may present, but again, it's very difficult because the fractions are very small. It's not that everybody who has had an eczema at the age of about 1 year is going to progress for something, that they may remain all right for a long period of time. Another thing is about the biomarkers. So there are several biomarkers, as I already mentioned, about you have the IL-4, IL-5, IL-9, but normally in our clinical practice we don't use these biomarkers per se. So it's more to do with the history and the clinical presentation, and you go about it that fine, this, you label them once the patient has a typical picture of an asthma. Because just remember one thing, that in children you get a very classical हिस्ट्री बड़ी क्लासिकल होती है, बच्चों में वो प्रॉब्लम नहीं आती है। आपको पता है कि हाँ, बच्चे का फादर स्मोक करता है, उसको खांसी हो रही है, दैट टिपिकल लेट इवनिंग्स एंड अर्ली मॉर्निंग्स, दे आर वेरी टिपिकल काइंड ऑफ अ थिंग। एक्सपोजर टू द डॉग्स एंड ऑल दोस थिंग्स इज वेरी कॉमन, कि बच्चा अपने फ्रेंड के घर गया, वहां डॉग से एक्सपोजर हुआ एंड द चाइल्ड वाज कॉफिंग द होल नाइट। सो यू हैव अ very classical picture in most of these children, so it becomes a bit easy, that part.
Okay, so I think what genetics, and we have covered that part in early onset allergic asthma. Again, the biomarkers are we check for IgE and IL-4,
See, the
IL-5,
basic,
IL-30.
the basic ones are CBC, CBC,
हाँ, वो
AEC,
तो जो
IgE,
है मतलब
PCR,
these are the
HSCRP.
yeah, of course.
वो तो
So
standard है,
Deepak,
but there are certain times, the people who want,
the
अब
treatment
जैसे
में
IL-4
जो
है,
early onset allergic asthma are probably the best ones to treat, are the most satisfying, gratifying, corticosteroid treatment. Inhaled corticosteroid से बहुत अच्छे से responsive होते हैं. They are very, 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 very good to go ahead with. So
and I would like to put forward on one account, as far as the treatment part is concerned, that you're giving inhaled corticosteroids and bronchodilators. If you see, a lot of pediatricians use left, right, center bronchodilators, and most of these children, the early onset ones, if you just use the basic corticosteroids, you don't even use the bronchodilators, they respond really well to the treatment.
yeah, again,
you don't need
ये होता
bronchodilators.
है, मतलब बहुत लोगों में ये प्रॉब्लम मैंने देखी, पीडियाट्रिक पर्चे मैंने देखा, इवन माय वाइफ इज अ पीडियाट्रिशियन, मैं जब पीडियाट्रिक
इप्रावेंट और वो इप्राट्रोपियम एंड एस्थलिन का कॉम्बिनेशन मिलाकर वो देना ही देना है वो, एंड दे डोंट गिव स्टेरॉइड.
ओके, सो दीपक, आई एम कमिंग टू यू. एक पेशेंट है, तूने उसको आइडेंटिफाई कर लिया, इसको टाइप 2 इन्फ्लेमेशन है, टाइप 2 एसोसिएटेड एलर्जिक सीवियर एस्थमा है, and you're thinking to prescribe anti-IgE. So how would you go about it?
So again, as I mentioned, that first we have to separate that whether it is difficult to treat asthma or it is severe asthma. And we are now going for an anti-IgE therapy. So IgE plays a very important role in inflammation. It actually binds to the high affinity receptor and causes the inflammation and inflammatory markers to rise. So what IgE we have available with us is anti-IgE therapy is omalizumab. The problem with omalizumab is that you have to calculate the total IgE levels, and then you have to titrate the dosage, and you have to titrate whether it has to be given fortnightly or monthly. Again, that is again weight-based. Weight bands are there for those IgE therapy. For these patients who have higher total serum IgE level and eosinophilic counts are not that much raised, these patients we do select for having anti-IgE therapy.
So what AEC should be there to choose from choose the patient from 150 to 1500? That is the or you can
that
go
is,
ahead.
more than 150. That is serum IgE level more than 150.
Yeah, more than 150
Yes,
to 1500, right?
to 1500. Yeah, but
And dosage will
again,
depend on that.
on the weight band and the total serum IgE. And also, if it is more than 1,000,
at 4 months of treatment of omalizumab, we review the response to the treatment, and and then we decide whether we have to give the treatment further or not. And then we can, taper down the inhaled corticosteroids or other treatment. And while if the patient is a good responsive, we can just taper down other treatment. And the duration of treatment is, I guess, 18 months to 2 years, I guess.
yes, up to 2 years.
Yes.
But again, for anti-IgE therapy, it is just like other MABs. Many of the patients continue till they don't even continue till 2 years.
Okay. So, Anand sir, so what are your ideas about eosinophilic asthma?
Yeah, as you have also presented in your presentation, eosinophilic asthma is a very important because if we talk about the endotypes, there are two. The one is inflammatory endotypes and I think non-inflammatory endotypes. Inflammatory endotypes are especially associated with the eosinophilic asthma. So the eosinophilic asthma is generally atopic. It may be associated with the Th2 pathway, and generally they presented as a allergic asthmas. But if we talk about the eosinophilic asthma, there are some competitors of eosinophilic asthmas as well in the OPD setup. When we encounter the patients, there are different criteria which we have to assess to make the diagnosis of eosinophilic bronchial asthma, because TPE, Loeffler syndrome, or we can say this Churg-Strauss syndrome may also be mimic just like a bronchial asthma along with the AVPA. So if we talk about the bronchial asthma as it is, then the sputum eosinophil count should be more than 2%. That will be considered. Along with that, if the eosinophil count that is more than 150 per DL, and in few societies it will be considered as more than 300 per DL, as well as the IgE level, it should be raised. If it is there, then we can consider the patient having the eosinophilic bronchial asthma. Definitely the peripheral eosinophil count matter, but the sputum eosinophil count will be considered as most important biomarkers to declare the bronchial asthma as eosinophilic asthma.
So, a sputum eosinophil of more than equal to 2%, 2%, and again this absolute eosinophil count should be more than
150 per DL, or in
more than 150,
by the few
and
society it will be assessed more than 300 also.
yeah.
Generally we can say as per GINA guideline it is more than 150 counts per DL.
यार दीपक भाई एक बात बताया मेरे
को एक चीज पूछना है, एक चीज ऐड करनी थी। वो अभी कृष्णा अन्ना का मैसेज आया है कि वी हैव अबाउट 1108 लॉगिन्स एज ऑफ राइट नाउ, लाइव लॉगिन्स।
थैंक यू सो मच। एंड मेरे को एक चीज बता दीपक भाई कि यार ये इस्नोफिलिक एस्थमा का जो ट्रीटमेंट है यार, ये मेपोलिजुमैब, रेसलिजुमैब, बेनरेलिजुमैब, यार सेम टारगेट है, ठीक है, 3 दवाई बनाने की क्या जरूरत है यार? एक चीज बताओ मेरे को, एंड व्हिच वन टू यूज एंड हाउ डू यू चूज?
So firstly, it's all about the availability, right?
Yeah.
Whatever is available with you. Secondly, now the difference if you see between benralizumab, mepolizumab, and reslizumab. So presently, I don't have any experience of using reslizumab. It comes with IV infusion. And regarding benralizumab and mepolizumab, so in this benralizumab, the treatment becomes after first 3 doses, the treatment becomes twice monthly. So the patient is more compliant with it. And if we see the pharmacology, so benralizumab is having IL-5R alpha receptor affinity.
Yeah.
Is there, while it is the mepolizumab is having broad spectrum. So recently,
so, 2 of them are indirect. Reslizumab and mepolizumab are indirect, and Benrali is a direct
one. Yeah. So, and recently the paper which was published by David Langton, it showed that the benralizumab fares much more better than mepolizumab in
That's
patients
what.
of severe eosinophilic asthma. But again, see, the thing is that we have to ask our patients, see your, as you rightly mentioned earlier, whether tier 2 city, tier 3 city. Again, you
Yeah,
have
we
to
have to
ask
face the
patient
reality.
availability. Today,
Availability, cost. Yeah,
yeah,
it comes down to the two factors.
two factors. And see, the cost is nearly the same, mepolizumab and benralizumab, if we see the 6 months therapy. But again, one more question which arises that if I am presently practicing in Nagpur, if I need to arrange for a benralizumab or mepolizumab, I have to tell the representative, or I have to pre-order it. It's not that the patient comes walking to me and I tell him that tomorrow I'm going to give you any kind of
Yeah, of course,
antibiotic.
that is true. But I guess GSK is actively marketing mepolizumab now.
They are actively marketing, but again, the subset of these patients receiving it is too low.
Yeah.
And many a times it happens that you have to procure it from Mumbai or Hyderabad, then it is transferred to
हाँ भाई
the city.
वो एडवांस वाला सिस्टम है पहले एडवांस जमा करो फिर
Correct,
दवाई आएगी फिर
correct,
लगेगी
correct,
आई
correct.
गेस that is the bitter truth about biologicals with us in India. That is downright reality. But
And
yes,
and
this was the case with a lot of things a while ago, good 5-10 years ago, and now they have become a common practice. So I assume biologicals will become a part of our practice very soon.
it has already become a part of it, but presently, if you ask me about the patient's mentality, as it was rightly mentioned, that the patients are firstly they are not accepting that they are having asthma. Then prescribing them a injection in today's world also we are striving hard to explain patient about inhaler techniques, the newer inhalers. Still, they are going for a fish therapy in Hyderabad. I don't know how effective it is.
नहीं फिश थेरेपी ओ माय गॉड मेरी ताई जी ने लिया है वेट टू मतलब शी हैज टेकन फिश थेरेपी एंड लाइक कोई काम नहीं आता है बट इट इज जस्ट
But
साइकोलॉजिकल रिलीफ
but again, explaining these people about going for biologics. I'll give you one small example of a lady, severe asthma, severe eosinophilic asthma, right candidate for benralizumab or mepolizumab. Coming down to me, she is like again comes for exacerbation, gets admitted, gets treated, goes off. Now is on homeopathic medicines. Came again with exacerbation, not taking inhaler, and minded. Now homeopathic doctors were prescribing her some nebulized therapy. It was not, there was no label on it, frankly speaking, but she was using those. So for these patients, explaining them for a benralizumab, they will spend a lot of money on partying and everything. She's a young lady, always
नहीं
get
वो
exacerbation
इन
after
सब
coming.
पेशेंट्स में रिवर्स साइकोलॉजी बहुत काम आती है मतलब पर्सनल एक्सपीरियंस रिवर्स साइकोलॉजी इज रियली इफेक्टिव
So, but again, see, again, it comes to the cost. Na? We are in a country where the complete treatment psychology is about the your financial dynamics rather
yeah
than
of course
actually what is. See, I was having a discussion regarding an exacerbation cost patients around 50,000 to 1 lakh rupees, depending on the setup in which they are getting admitted. They are ready to spend that rather than taking an injectable which is actually saving them from such life-threatening exacerbations. So mostly they are very keen on taking intermittent treatment rather than for a prolonged time. And the question always arises that till how long you have to give. So mepolizumab data has come that 5 years data is there. Benralizumab at least 2 years you have to continue with these patients on.
every
So
4 weeks every 2 weeks this is hey, it is too much on the pocket
too
right
much on the pocket, yes.
yeah. So I have a question from Kalaburgi, Karnataka. Aditya, sitagliptin asthma में कोई connection होता है क्या?
Sitagliptin prescribed with anti-diabetics. So sitagliptin, I came across some time back a paper from Taiwan. So they were using sitagliptin for the anti-diabetic for the diabetic patients, but they observed that the sitagliptin had an anti-inflammatory effect. So the patients who were suffering from bronchial asthma and were diabetics, they suffered less of exacerbations. Their rate of hospitalization was less. So they came to a conclusion that it does play a little role, but there's no studies per
Conclusive
se done.
evidence.
No conclusive.
metformin का
GINA
study है
guideline will not support
I
all
think
this.
what I've seen in my experience with sitagliptin in adult patients is that at times, their urticarial issues increase. That's what I
Okay.
have seen with the gliptins. I would not say sitagliptin. I would put it as with the gliptins. So that has been there, and the moment you stop their gliptins and shift them to some other category of drugs, the urticarial issues go down. So I'm not, aware of the asthma part, but this has been my experience.
There is just
Wonderful,
a
sir.
vague study about metformin and Th2 response, but it's very obscure and just one or two of studies.
Okay. And just wanted to, your idea on, this new entity that has been described, like aspirin exacerbated airway disease. Could you throw some light on it, Aditya?
So, as the name suggests, aspirin associated respiratory disease, that means it is being exacerbated by the intake of NSAIDs. So now these NSAIDs, they activate those pathways that lead to secretion of cysteine leukotrienes. So whenever there is an exacerbation of asthma, they may be suffering it from because of NSAIDs per se, and the you can come to a conclusion that they are exacerbated by the NSAIDs, the sputum eosinophils, the blood eosinophils, and presence of leukotrienes in the blood.
Okay.
LT6, yeah.
So how do you treat that patient?
So you stop giving them NSAIDs.
And apart from that, any other treatment? अब किसी को
Apart from that,
देनी
you give standard asthma.
standard
Yeah,
asthma
the standard
and
asthma treatment
Montelukast
you
is probably one of the
correct
drugs that help,
antihistaminics,
right? Right.
right.
Just to add on to what Dr. Aditya was telling, so during COVID, everybody gave aspirin to the patients, right?
Yeah.
So post-COVID, I just retrospectively analyzed the patients which I have seen. So there were many patients who were labeled as post-COVID HRAD or hyperreactive airway disease or viral bronchitis, what we say, were actually having aspirin-induced asthma. I had data of about 100 patients of such.
You should publish a paper upon it, dude. You should go ahead and publish a paper. I think this would be a tremendous presentation. Though many of us were using Eliquis, but I think a good number of our friends might be using aspirin also.
So then the recovery trial which came, it told that you should not use aspirin, and then many other trials came which told that you should not use even the low molecular weight heparin to the extent of therapeutic dose. You have to just give the prophylactic dose to the patients who are getting admitted rather than the ambulatory.
But Deepak, going off track here, like for the benefit of population, I had many patients who had suffered from cardiac events after discharge from 2 months, 3 months later. Had many patients who had suffered from cardiac. I think that was due to the blood thickness of COVID. And had we continued aspirin or Eliquis in those patients, even in prophylactic dose, things would have been very different. That is my opinion. It is not documented anywhere. I'm just telling you a fact.
Actually, it was multifactorial. So we can't comment on a single object or
Okay.
article that it is responsible. So a proper study is required. We can't say okay, it is through the NSID or it may be through some other deficiency or nutritional deficiency, or there is a fibrosis which may be present in the lung that persists for a prolonged period that may be responsible. So a proper study is required. So until proper study will be
I
conducted, we
think you
can't
are
comment
right.
on it.
Like मतलब ऐसा हो रहा है ना जैसे सब दोस्त बैठ गए तो मुझे लगता है थोड़ा डिस्कशन ऐसा इस तरह का हो सकता है. So let's come back to the topic. Role of small airway obstruction in asthma control, and your experience as you are one of the people who is using iOS and both FeNO. So small airway obstruction in asthma control and your experience of using iOS in day-to-day OPD practice.
So again, as we were discussing that the patients who come to us, that only 15 to 20% of these patients have classic obstructive curve. For these patients, many a times, see, what I believe that being a tertiary care physician, we normally see most of our patients are difficult to treat asthma. Had it been asthma which was being treated well or well treated asthma, they wouldn't have come down to us. If they have come down to us, there was every patient is using ICS LABA, or they are on any kind of inhaled corticosteroids or oral corticosteroids. So when they come to us, many times the spirometry is not revealing the exact FEV1, or it's sometimes, many times it is normal also. But these patients do have a history of severe exacerbations. For such subset of patients, iOS does help. And FEV1, in PFT also we calculate FEF 20/75, but it is not still that reliable. Impulse oscillometry does have a important role in patients who have severe asthma with small airway obstruction, because here you require some ultrafine particles to go down there and help the patient with those. If the patient is on high dose ICS LABA and is not being controlled, iOS does play an important role in that too.
ग्रेट सो श्रीराम सर, आप एक बात बताओ, एक्सरसाइज इंड्यूस्ड एस्थमा के पेशेंट देखे हैं आपने?
So the very interesting thing is I didn't know that this exercise-induced asthma is a big deal until I saw a girl in the OPD who was so scared that she was one of the athletes in this recently concluded Khelo India. She was so scared that if she's diagnosed with asthma, she'll be thrown out of the competition. She was a professional athlete, but fortunately for her, she didn't have asthma. So exercise-induced asthma is a big deal for professional athletes, and maybe it's overlooked in our day-to-day OPD also. It mainly occurs because of in cold environment and in exposure to pollens or other known allergens. The susceptible individuals, there is a increased change in the airway osmolarity and triggers the release of inflammatory cytokines.
So I
One of the
also Shriram boss, sorry to disturb you.
हाँ जी.
Please proceed and एक बार ट्रीटमेंट भी बताइएगा सर, इसको कैसे मैनेज किया जाएगा इन पेशेंट्स में?
So one of the issues with diagnosing asthma, exercise-induced asthma is many of the guidelines have recommended that it requires a proper laboratory with challenge testing also, such as hypertonic saline, and also you have to measure their FEV1s, at a fixed time interval baseline at 5 minutes, 10 minutes, 30 minutes into the exercise, into the strenuous physical activity. And a drop in FEV1 of more than 10% is recommended, is told by most guidelines as a diagnosis of exercise-induced asthma. Also, so it is managed. One of the most commonly studied molecules is a short-acting beta-2 agonist. It is known to be the most effective in exercise-induced asthma. It is given maybe 15 to 20 minutes prior to the strenuous activity and shown to have better exercise tolerance afterwards. As far as inhaled corticosteroids are concerned, which we so commonly use, it is not shown to have, you just take an inhaled corticosteroid and then engage in physical activity. That won't help. It has to be taken at least, it is recommended for maximal benefits to be taken at least 2 weeks prior to your intended exercise. Other molecules such as montelukast have also been extensively studied and shown to have great benefit in these subset of patients. They also are not instant ki montelukast liya and then you start, engaging in your sport. It also has to be taken like the ICS maybe a couple of weeks prior, and you have to monitor your FEV1 then. So apart from this, certain non-pharmacological treatments such as altering the environment of the exercise where possible should be done. Other than that, maybe avoiding obvious allergens such as pollens and other dust in your environment of physical activity also has shown to help. Respiratory muscle training, which the sports physiotherapists do quite often, that is one of the major non-pharmacological therapies which has helped athletes.
Okay, thank you for a very descriptive answer. So आनंद सर, मेरे को एक बार बताओ कि एक टर्मिनोलॉजी हम लोग के सामने अभी आ रही है, आई गेस जीना लास्ट ईयर में भी आई थी और इस साल की फिशमैन में भी है, सीवियर एस्थमा विद फंगल सेंसिटिविटी.
Yeah.
So how, what this terminology actually means?
Dr. Utsav, actually, the severe asthma with fungal sensitivity means something near to the AVPA, but it is not exactly the AVPA because few criteria of the AVPA will not get meet. So, if all the criteria which has been provided by the Isham criteria, the Rosenberg criteria, if it will not meet like serum IgE level that is more than 1,000, serum Ig specific increased, serum IgG specific for aspergillus get increased, or eosinophil count get increased. If all these criterias along with the CT criterias like HRCT have some features of bronchiectasis, if they not meet, then we can say the patient have this severe asthma with the fungal sensitivity. Because though it is near to the AVPA, but it is not exactly the AVPA. So there are more than 200 species of aspergillus, which is present in the literature. So it may be something else, or it may be the initial stage of the aspergillus fumigatus, which is in a window period. So we can say it is a fungal sensitive. The treatment is more or less the same as we prescribe in the AVPA, but we can't confirmatorily say that it is a case of AVPA.
So how do you treat it, sir? मतलब उसका treatment क्या है?
Yeah, once it get diagnosed, because there is a fungal element is there, so there is an inflammation. So Th2 lineage is affected. So the primary treatment is always, as you know, the steroid that should be given to such patients. If the patient not controlled on the inhalers, besides this, we should also give some isoles or the antifungal drugs like itraconazole or voriconazole that can be prescribed to such patients for a prolonged period. That is recommended around 200 milligram BD for 4 months. And if we talk about the steroids, then it should be given 0.5 to 1 milligram per kg body weight for the 2 weeks, and later it get tapered from 0.5 milligram for 4 to 6 weeks, and that get gradually be stopped. So it depends on the stages of the diseases and in which stage the patient lie, and what is the IgE level of that patient. If it get reduced 10% or if it is less than 1,000, then we can taper down the therapy gradually, or we can stop even the antifungal drugs, or we can put the patient on the maintenance therapy of the steroid for a longer period so that the symptoms get controlled.
So do we use itraconazole also in?
Yeah. We use the itraconazole that should be given in the dose of 200 milligram BD. There are a few studies which is
For how many months, sir?
It should be around 4 months.
Yeah.
Minimum 4
So
months.
4 months treatment along with it's basically what my understanding of your description is. SAFS, severe asthma fungal sensitivity, matlab looks like ABPA but does not
It is
meet the
just like
criteria of
ABPA.
ABPA.
There is only a single difference, or one or two criteria may be missing.
Yeah.
Maybe IgE specific, maybe high, but IgG specific is less, or there may be the criteria which are associated with the HRCT are missing. So if there are only a single criteria which is missing, we can't label the patient as a case of
Treatment
ABPA.
almost same ही होता है, बस थोड़ा सा ऊपर नीचे मतलब.
Yeah.
Right.
We have to control the symptoms. And generally, I have seen, this is my practice, that if the patients, those who are diagnosed these severe asthma with fungal sensitivity, they well respond with all the therapy which is actually recommended for the AVPA.
Okay, that's great. विभू सर, मेरे को एक चीज बताओ. विभू सर, जो है आप इट्राकोनाजोल बच्चों में यूज करते हो?
Not exactly indicated.
Not exactly indicated,
No,
right?
no. So as far as ABPA is concerned, we do it only with the oral steroids.
अच्छा, ओके. सर, मेरे को एक चीज और बताओ कि व्हाट इज योर असेसमेंट ऑफ यूज ऑफ बायोलॉजिकल्स इन चिल्ड्रन?
आई थिंक इसका आधा जवाब जो था वो पहले कहीं दिया गया था, जहां पर बोला गया था कि एक्सेप्टेंस ही नहीं है. सो एडल्ट की एक्सेप्टेंस ही इतनी पुअर है, तो बच्चों में यू एक्सपेक्ट के आप उसको बोलोगे इंजेक्शन लगवाओ. I mean, see, the cost factor definitely has a role, but the moment you say कि it has to be an injectable, you have to understand that जो parent है उसको लगता है पता नहीं कौन सी बीमारी होगी. So I think the acceptance is very, very poor. I had just one patient recently जिसने लगवाना शुरू किया है अभी ओमेलिजुमैब, बट उसका भी यही है कि उनका पूरा का पूरा जो है वो दे आर कवर्ड अंडर दिस CGHS बेनिफिशियरीज हैं, सो यू
वही
नो कॉस्ट
लगवाते
डजंट
हैं,
मेक अ डिफरेंस।
CGHS वाले ही लगवाते हैं सब।
हाँ, तो वो उसको
हर
फर्क नहीं
हॉस्पिटल
पड़ता,
की एक
और
ही
वो
कहानी
पेरेंट
है।
वाले के ठीक है पंप, अच्छा उनका रीजन भी थोड़ा सा ये है कि हाँ पंप भी हट जाएगा ये वो, तो मैंने कहा नहीं पंप नहीं हटेगा, बट यू नो इट्स लाइक they were kind of well read people and they are वो IAS लेवल का होता है ना कि वो सारा पढ़ पढ़ा कर और काफी गूगल से नॉलेज लेकर तब आए थे, तो आप ये शुरू कर दीजिए डॉक्टर साहब। मैं ठीक है डॉक्टर साहब को क्या प्रॉब्लम है, डॉक्टर साहब ने भी शुरू करवा दिया, but then the end point becomes a very big issue, I think. The end point is, see, what worries me mostly with these biologics is it's easier said than done कि यार ये end point है, 2 साल 5 साल 6 साल कुछ भी दे दो, उसके बाद क्या? I think most of
This
these
is very
patients,
important, and this is what many of us fail to discuss with our patients कि यार स्टार्ट तो तुमने कर दिया इस ड्रैगन को, अरे तुमने इसको you have left opened the gates and the dragon is out of the out of the
exactly,
cave, अब इस ड्रैगन को वापस अंदर कैसे डालोगे?
वही
That is very
प्रॉब्लम।
important, like we don't discuss कि यार इसका ड्यूरेशन क्या है, कितने दिन चलना है, ये सब, क्योंकि पेशेंट।
And I think we are being misled with a lot of studies also. I mean, I'm as far as
I
this
agree.
labs are concerned, इसमें हम लोग I think we have been highly misled with the stuff, because you are being told कि okay you give it for 1 year. I think omalizumab when it came 1 year, 18 months कई चीजें आती गई, and we just tried कि ठीक है, but then eventually after that what, the patient is all right for 3 months and then comes back with the same issues,
वापस से
ऐसे कि
But
डॉक्टर साहब
I
इतना
guess
पैसा खर्चा
पता
किया।
है, मेरे को ऐसा लगता है, मतलब we'll definitely talk to higher ups, but we should have an Indian paper or Indian statement, or like we have an Indian statement of asthma, COPD, pneumonia, we have an Indian statement recently of thoracoscopy guidelines, Indian thoracoscopy guidelines, हमें एक इसके ऊपर मैप्स के ऊपर भी ना एक इंडियन अपना वो आउटलुक एक रखना चाहिए कि यार ये हमारे इंडियन सिनेरियो में ये चीजें होती हैं, एंड यू शुड थिंक
Because
अबाउट इट एंड डू अबाउट, मतलब कि
see,
यार हमें कैसे मैनेज करना है इस पेशेंट को।
अगेन इट्स इजियर थिंग इज कि ठीक है पेशेंट को चलिए आपका बेनिफिशियरी है उसको मिल रहा है, बट देन एट द एंड ऑफ द डे उसका अगर एंड पॉइंट नहीं है, आप सोचो जब वो बच्चा उस वाले पॉइंट्स, बिकॉज जो उसको मैंने लगाया वो 15-16 ईयर्स वाला बच्चा है, अब क्या आपने सब किया सब कुछ ठीक है, वो 18 के बाद जब वो अपने पेरेंट के उस आउटफ्लो के बाहर निकलेगा, उसकी कवरेज नहीं भी होगी अगर, देन व्हाट विल हैपन? So we have to think, and the cost factor definitely is a huge issue. So I am a very,
Definitely.
very conservative person as far as MABS is concerned.
Dr.
So,
Kumar, I just want to add one thing.
yes, sir.
Actually, if we talk about the biologics in a bronchial asthma, that is actually a last resort. And if we talk about the severe asthma, that is 3 to 4% of the entire proportion of the asthmatic cases. So once the patient not responded to the even oral steroids, and there are a lot of side effects which appear. So we have one thing in our hand that can be used if the patient required. Nothing else. We don't think we should put the patients when they tolerate inhaled corticosteroid even in a maximum dose.
Yes.
वंडरफुल। सो सर मेरे को एक चीज बताओ ना, एक और अपना फिनोटाइप होता है, जैसे एस्थमा फिनोटाइप एक है फिक्स्ड एयरवे ऑब्स्ट्रक्शन वाला, तो सर कैसे आप डिफरेंशिएट करते हो, मतलब कि ये सीओपीडी नहीं है या एस्थमा है, दिस इज द एस्थमा फिनोटाइप ऑफ फिक्स्ड एयरवे ऑब्स्ट्रक्शन, हाउ डू यू गो अबाउट इट, एंड व्हाट इज योर आइडिया अबाउट एस्थमा विद फिक्स्ड एयरवे ऑब्स्ट्रक्शन?
Yeah, actually, you are talking about the echo, that is asthma COPD overlap. Because
Yeah.
when we talk about the fixed airway obstruction in the asthma, then it makes the asthma and COPD both. So there are different criterias which may define the echo worldwide, but the most acceptable criteria, that is the major criteria and minor criteria that has been provided. So few societies or the few researchers says there are 2 criteria major and 2 criteria minor will be accepted, or 3 criteria major and 1 minor will be accepted. So the criteria, if we define, then there should be persistent airflow more than 40 years of age, and the smoking habit that is more than 10 pack years, that should be there, or he must be diagnosed as a case of bronchial asthma before the age of 40. That are the major criteria. Either we can take 2 criteria or 3 criteria. And there are few minor criteria that also be considered. The one is either the patient may be atopic, or there should be reversibility with the bronchodilator therapy, or eosinophil count that is more than 200 per DL. If the single point will be there, along with the three major criteria, we can label the patient as a ACO. The one new criteria which has been added, that is FeNO, FeNO. If it is more than 35 part per billion, then we can also add. So if all these four minor criteria, even a single criteria will be there, along with three major criteria, we can label the patient as a ECHO.
ग्रेट सर मेरे दीपक भाई मेरे को एक बात बता यार, ये एक और फिनोटाइप हम लोग होती है, क्लिनिकल फिनोटाइप, दैट इज कॉर्टिकोस्टेरॉइड डिपेंडेंट एस्थमा. थ्रो सम लाइट अपॉन इट डूड.
Steroid dependence, nothing but severe asthma who requires continuous corticosteroids. Now we have this biologics which are used as a corticosteroid.
That is like 90% patients of severe asthma in our day-to-day practice, right?
Correct. And thing is that for as it was mentioned earlier rightly, that the biologics are to be used as a corticosteroid sparing kind of treatment. So most of these patients are severe eosinophilic asthma, because as we know, we were talking about the fixed airway obstruction. So mostly these patients are neutrophilic asthma. For these patients, even corticosteroid treatment is not very
not
effective.
responsive, right?
So for them, we are normally giving macrolides, and now they're trying for MABs also against IL-17. But still, these patients, as we know, that these patients who get a steroid tablet OTC, they do tend to take these tablets very
खाते रहते हैं यार वो, घर पे वो कितने ही सालों से खा रहे, वो डेक्सोना लगा के, डेरिफाइलिन लगा के, बेटनीसॉल लगा के, मतलब काम चलाए जा रहे हैं. Until the time they come to us, they're ruined. They're basically ruined.
Correct. So
Dr. Kumar,
I had a patient who developed perforation peritonitis secondary to a gastric ulcer, which had developed because of constant use of betnesol for last 40 years.
How many patients of TB do you see because of
A lot.
chronic use of
A lot.
betnesol in
So-
rheumatoid arthritis itself? Rheumatoid RA के पेशेंट जो गांव में इलाज करा रहे हैं, उनको बेटनीसॉल की टैबलेट दी जा रही है, वो खाए जा रहे हैं,
So
TB हो जाता है.
one of the asthma mimic is your endobronchial tuberculosis. It presents
Yeah,
with
of
wheezing,
course.
it has cough, it has dyspnea. So we need to evaluate patients on that terms as well. So many a times I'm now getting patients of cough tracheobronchitis even. I have around data of around 20 patients recently who were on like oral corticosteroid for different therapies, but developed had cough which was not responding to anything. It did a bronchoscopy. It came out to be AFB as well as gene expert positive. So labeled them as cough tracheobronchitis. This is earlier stages of your endobronchial tuberculosis.
Yeah. So you'd be surprised कि कितने पेशेंट को, मतलब जो एस्थमा के ट्रीटमेंट में वो वीज किए जा रहे हैं और लोग एक्सरे नहीं करा रहे हैं, और बाद में आप एक्सरे कराते हो, हल्का से लीजन आता है, आप उस हल्के से लीजन को फॉलो करते हो, सीटी कराते हैं, goes on to become early diagnosis of tuberculosis. So यार आदित्य, मेरे को बात बता, you are sitting in the country's capital, you are sitting in one of the best institutes, Delhi जहाँ पे CGHS भी है, ECHS भी है, और तुम्हारे सारे इंश्योरेंस कंपनीज हैं, सारी चीजें हैं in your center in Jaipur Golden. Tell me, how do you choose patients for biologicals? मतलब अपने पेशेंट को कैसे चूज करते हो? तुम्हारे पास you have every drug available in Delhi.
As Dr. Anand said, when your own treatment is not working on the patient, the steroids have been amped up, oral corticosteroids are being given, injectable corticosteroids are also being given, and then the patient gets relieved and again lands up in the same situation. And the serum IgE does not come down, you get repeated levels of IgE done. So those are the times when you turn towards biologics. And the patients who are CGHS beneficiaries, it is a boon to them, and they get these biologics from the dispensaries. We inject them, and they are from years together. I have been treating two patients. They are on third year of omalizumab they are taking. Every 15 days, 150 milligram injected, and they are doing well. बीच में एक बंदे ने बंद किया था, आफ्टर 2 years बंद किया था, for 3 months 4 months it was fine, he came for the OPD consultation, it was fine, again he landed back in the same exacerbation, so we put him on the lifetime IgE therapy.
Okay, we've talked a lot about type 2 inflammation, biologicals which are useful in type 2 inflammation. And let's come to the next part of the discussion. We have a very short time. Non-type 2 asthma. Deepak, how do you describe a patient of neutrophilic asthma phenotype?
So these are the patients who are actually not responding to your current therapy. These are the patients who come late onset, have more of exposure to smokes, and also these patients are obese. And these patients, your FeNO would be normal, will have obstructive airway disease. Mostly these patients have fixed airway obstruction. Yes, we don't frequently do the sputum neutrophil count, but in those patients, the neutrophil counts in sputum is raised. Many of the studies have done bronchiolicular lavage also to show that the neutrophil count is up to 20%, 20 to 40%. So these are those subset of patients who are not responding. They come with severe exacerbation, but study mentions these exacerbations to be less severe than the eosinophilic ones, and the therapy which is given to them is mostly macrolide therapy.
Great. So macrolide therapy along with treatment of
Asthma.
treatment of asthma. So there is a terminology called perimenstrual asthma. Shriram boss, perimenstrual asthma. Any ideas? And how do you treat that?
So perimenstrual asthma, though at least I have seen just about one case maybe. I think this is one area where we need to the treatment during the treatment we need to take some form of assistance from our gynec colleagues also, because this in the initial part of the luteal phase of the menstrual cycle, because of imbalances in progesterone and estrogen levels, there is a mast cell degranulation in the endometrium, which is systemic in susceptible individuals. Around there is a significant amount of women in the menstrual age group that it affects, around close to 40%. So what the treatment involves, surprisingly, oral contraceptive pills in a specialized regimen. They just have to increase the duration of the oral contraceptive pills so that some form of an hormonal stability is achieved. And this is shown to help the patients a lot, apart from correction of anemia and our routine asthma treatment. So I think this is one area where, though the disease, the mast cell issues is in the endometrium, but it is systemic in susceptible individuals.
I think I see a few of such kind of cases. The young girls come to us, and what happens is they're usually mild asthmatics, but their issue becomes, because I think it's more to do with the hemoglobin part. They have a hemoglobin issue, and that basically it's not exactly asthma. They're breathless because of the low hemoglobin which is there. And I've seen it quite frequently. I mean, the young girls coming these days with the hemoglobin level of 9 and 10. I mean, I'm like, you belong to good families. You have a good, everything is good, but the kind of food habits, I think, play a very important role. So per se that that okay, asthma is happening. Yes, it is.
ये चिप्स
As
और
you
फ्रेंच
mentioned.
फ्राइज की जनरेशन है बॉस.
नहीं, एक चीज और है, मैं मतलब पूरे डिस्कशन के अंदर, सो आई एम जस्ट टेकिंग इट आउट ऑफ दिस क्वेश्चन आल्सो, कि आप तो जैसे वाराणसी से हैं, तो आई थिंक वाराणसी और मध्य प्रदेश में तो होता था, बट यहाँ पे भी है वो आजकल भभूति का बड़ा चीज है. एंड दे आर गिविंग सम पाउडर्स एंड ऑल टू द पेशेंट्स, बिकॉज आई हैव बीन गेटिंग अ लॉट ऑफ पेशेंट्स जिनको जैसे होम्योपैथी वाले तो सफेद रंग की गोलियां देते हैं. यू डोंट नो व्हाट्स देयर इनसाइड देयर. But once the patient has taken those kind of medications for a period of about 1 to 2 years, believe me, matlab, what I've seen, that even children, around 14, 15 years old, they respond very poorly to your basic treatment of asthma. So
उनके
can
साथ
you
भी
throw
सर
some light
कांड हो
on?
चुका होता है. सही बात है.
नहीं, पर क्या चीज होती है, मतलब आपको क्या लगता है, what could it be? Could it be just
सर वो जो
steroids?
विभूति है ना,
वो पिसा
वो
हुआ
विभूति
कॉर्टिसोन
देह
होता है
से,
बस.
हाँ 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 हाँ
पिसा
हाँ
हुआ कार्टिसोन होता है और कुछ नहीं होता है. मतलब दिस इज फ्रैंक एक्सपीरियंस पिसा हुआ कार्टिसोन होता है, वही होता है। और सफेद गोलियां जो मतलब आपको डब्बी में भर के देते हैं गांव में, वो भी जो बेटनीसोल की गोलियां होती हैं,
वाइसिलोन,
वाइसलोन की टैबलेट्स होती है, उसको
Varanasi,
डब्बी से निकाल के, मतलब I've seen so many patients ruined by it। डायबिटिक पेशेंट है, खाए जा रहा है, उसको पता ही नहीं क्या खाए जा रहा है, मतलब चल रहा, और फिर टीबी भी हो गया, डायबिटीज भी हो गया, शरीर की पूरी बैंड बजी पड़ी हुई है। तो दिस इज वेरी कॉमन इन आवर पार्ट ऑफ द कंट्री। एक मेरा क्वेश्चन है, आनंद सर, यू आर द सीनियर मोस्ट, और ये क्वेश्चन हमारे चैट बॉक्स में भी आया था, ओबेसिटी रिलेटेड एस्थमा सर, थ्रो सम लाइट अपॉन इट।
Yeah, obesity, we can say the morbid obesity, because obesity itself is not responsible for bronchial asthma. But if we talk about the morbid obesity, if the BMI is more than 35, then it may be related with some issues, and that comes in non-inflammatory type phenotypes of bronchial asthma.
So what
Especially,
biomarkers do you use, sir?
yeah, if we talk about this non-type 2, so the biomarkers are definitely interleukin 17 that will be used, as well as the interleukin 33 that can be utilized for the making of diagnosis of it, because it is a neutrophilic kind of uh, bronchial asthma. So the sputum neutrophil count is also important. If it is more than 30 to 40%, then we can say it is a non-inflammatory type of bronchial asthma. Rest of the things, because there is a mechanical issues. There are three pathophysiological mechanism which is responsible for the obesity-induced bronchial asthma. That have one is mechanical, so there is a expiratory reserve which get reduced because of fat deposition on the chest wall as well as in the abdomen. So there is a diaphragmatic movement that get reduced. Besides this is a non-inflammatory type, so neutrophil count get increased. So inflammatory mediators like interleukin 17 and 33 that can be increased. So leptin hormone is also responsible for the same. So the leptin that could be assessed. So the leptin is responsible for the inflammation in the lung, and it may be responsible some derangement because it generated in the body and responsible for the inflammation also. So adipocytes uh, as well as granulocytes, the both are involved in the pathogenesis of obesity-induced bronchial asthma. So yeah, so these are the factors.
So Dr. Jairam from Chennai has asked a question on this topic, that obesity phenotype are mostly steroid resistance. Will you advise weight reduction or CPAP therapy or a non-CPAP therapy?
Actually, if we see the guidelines, then CPAP therapy, BiPAP therapy is only recommended, CPAP therapy recommended only for the obstructive sleep apnea. But here, if we talk about the obesity, bariatric surgery is important, because many research which has come up, it shows if the weight reduction will be there, nutrition control is there, or we can reduce the weight 30% or 40%, we can drastically see the changes among the patients, and the symptoms of bronchial asthma get exponentially get reduced.
So, yeah, definitely. So what I get from your discussion, sir, Anand sir, is that it's a comprehensive approach. It's it's just not one thing. You have to have the weight reduction, introduction of exercise, and PAP therapy, counseling, psychological counseling, depression counseling. A lot of things are included, and that will lead to the overall treatment apart from the medicines you are giving.
Yeah,
just
exactly.
or giving orlistat and these drugs which are available for weight loss, I don't think they are the appropriate answers. Sitting with the patient, giving time to the patient, having the patient meet the dietitian and everything, that I think that is where the future lies. So one more question I have from the audience, from Dr. Anand from Tamil Nadu. So whether skin prick test can be done in identifying specific allergens in allergic asthma. So Dr. Anand, I guess we are doing skin prick test in our setups. We are doing at our center and identifying specific allergens in allergic asthma. And then we tell the patient to avoid these allergens. And if we have the possible antidotes to them. We give the treatment to the patient, and patient respond wonderfully well. That is with the answer for that. I guess we have completed our time limit here, and you have been, an amazing group of all of you. Love all of you, my friends, and I thank you all my audience. It is for you that we do this show. It is for you that we work hard and burn the midnight oil, and it is for you that we are here. I personally want to thank Dr. Atri and Dr. N.H. Krishna sir, Narayan Pradeep sir, Chinnam Chetty sir, for helping me out with this presentation at times where I was lagging behind, and for extremely cooperative panelists जिनको मैंने बहुत परेशान भी किया है बीच-बीच में इंटरप्ट करके. I am very sorry for that. Forgive me. Thank you, Shriram sir, Vibhu sir,
Thank you, sir.
Anand sir, Deepak sir, and Aditya sir. Thank you so
Thank you
much.
all
Thank you,
of you.
Vas. Thank you.
Thank you, Dr. Utsav. And I think, CCI webinars are always a kind of a fun for me. It's a fun and learning, because when I interacted with you, I think we met once in the NAPCON.
Yeah,
Thanks to
we met.
Aditya.
Yeah, first
We
time
met
in Delhi,
once.
right?
And अब आज लगता है यार कि अब नेक्स्ट जब वाराणसी का चक्कर लगेगा तो I'll definitely see you.
आओ सर, आ जाओ, बनारस आ जाओ, कोई दिक्कत नहीं.
बनारस तो आ ही जाएंगे, वहां तो आने पर सारे पाप तो वही धुलते हैं ना.
सारे पाप तो हमारे धुलते, पाप करके हम यहाँ सब धो देंगे. थैंक यू सो मच.
चलो, take
अगर
care, boss.
आपने
Good night.
और
Good
सुना
night, everyone.
और सुना तो
Night.
और भी बहुत सारी बातें बाहर निकल सकती है. So I'll put a stop to it. You have been an amazing audience. Thank you so much.
Thank you. Thank you to the entire CCI family. Thank you.
Thank you.